Multimorbidity increases probability of high intensity end-of-life care, which is not surprising. Advanced care planning documentation completion can mitigate this cost, and patient engagement is variable and can be influenced by the use of a shared decision-making tool, which is what this quality improvement project focused on. Next slide, please. The rationale used behind it, I focused on a domain of patient-centered care. The framework that we followed was a shared decision-making model, and the tools that I chose were the Where I Stand scale, which is a 2-page, 8-question guided conversation piece that walks you through an entire discussion with the patient regarding goals of care, end-of-life care, family contribution to these decisions, and so forth. And at the end of that, everyone completed a mean sure test, which assesses for decisional conflict. This is a 4-question questionnaire, and typically the patients, we saw some pretty consistent collection of data from that. Mostly, almost everybody was a 3 on this, and the highest score is 4, and a 4 indicates that you are not in conflict regarding making a decision. Next slide, please. Our specific aim was to increase the engagement of patients in the filing of documentation for advanced care planning to 50% within 8 weeks using this shared decision-making tool. Next slide, please. The methods that we followed were, this was conducted in an outpatient heart failure clinic in Louisville, as we talked about before. Predominantly, our population is white. We have been working on remedying this. We've been trying to work on diversifying our patient population by doing some community outreach, and hopefully that changes over the next 3 to 6 months. 68% of our patients are on Medicare. 52% of them are male. This study followed 4 Plan, Do, Study, Act cycles, or PDSA cycles. These were bi-weekly, and every 2 weeks we formulated a test of change based on the data that we collected from these PDSA cycles. Next slide, please. Within those cycles, intervention 1, the first cycle, of course, was just implementation of screening. So screening was checking to see if these patients had ACP documentation on file. And something that we found in this initial cycle was that several patients thought that they had documentation on file, but it either hadn't been filed appropriately, or it hadn't been turned in, or the EMR simply wasn't recognizing that it was in its proper place. In the first cycle, we also noticed that our front desk staff, which we only have 1 person who does that, was having difficulty keeping up with her job burden, because she was trying to have these conversations and screen these patients within that realm. And we have 2 roomers at the time, a nurse and a medical assistant. So in PDSA 2, we transitioned that screening process to them, which split that burden up by 50%, and that helped tremendously. In PDSA 3, I reached out to our advanced care planning coordinator to discuss with her the number of patients we were finding that had advanced care planning documentation, but we weren't able to track exactly where it was, or it wasn't appropriately documented within the EMR. The EMR that we use is Epic. And typically it's supposed to have a flag on the front page on the sidebar stating whether or not they have these documents on file. But unfortunately, there was no efficient way to create a report and weed these patients out without going through and doing manual chart review. And during that cycle, we also noticed that as some of our staff members were out, our medical assistant was much busier trying to ring these patients, so she was sometimes forgetting to hand out the packets with the shared decision-making tool and the mean sure test to the patients. So we moved those next to the door so that they were at eye level and plainly visualized on her way out, and her utilization moved up to 100%. Intervention 2, again, PDSA 1 was just implementation of the tool. During PDSA 2, I thought it might be helpful to have a weekly staff huddle. This morphed into a one-time only staff huddle where we all reconvened, everybody on the team that was involved, and just discussed how we felt the project was going, what changes we could make that might make it more efficient or more useful. And that we found that to be very helpful, but not necessarily something we needed to replicate. In PDSA 3, I thought that I was maybe detecting a relationship between the severity of their NYHA heart failure class and the mean SURE scores. So I began tracking that data on this side. There was not necessarily a correlation after I reviewed that. And then in PDSA 4, we were trying to track the sicker patients who were at higher risk for readmission with NYHA class 3 to 4 heart failure to get them in for a 1-week follow-up if they were unable to fill out the paperwork during that visit, just to try to be able to better get that on file. Next slide, please. In studying the intervention, we used surveys to collect raw data. These were created within Google Forms. The aggregate data charts were created and run into a run chart within Excel, and this was used to analyze to create the tests of change. Those were developed based on the analysis, and typically we were discussing amongst ourselves throughout the project outside of that staff huddle, and we got a lot of feedback from the staff members, the support staff members, in terms of evolution of those tests of change. Next slide, please. So for measures, for the screening, I had created a form, and for the process, we just took the number of patients screened over the number of patients seen, and the outcome of that, of course, being the number of patients who screened positive or did not have advanced care planning documentation on file, was the number, those were the patients who received the intervention. The intervention being the shared decision-making tool Where I Stand scale and mean SURE test, which were all on one form. And the formula that we used to process that was the number of tools used divided by the number of eligible patients. And we had pretty good results with that, as we'll get to later. And the outcome we measured as the mean SURE test score, which we did not notice a whole lot of variability with. Next slide, please. The run chart and aggregate data charts were assessed for any astronomical points, runs, trends, shifts, and all of this was rolled into a quantitative data log of the mean SURE score and the ACP screening data. The qualitative data that we managed was a team engagement survey that I created within Google Forms. This was just to see initially, prior to implementation, if the staff members felt comfortable even initiating this conversation with patients, because what we found is that our staff members came from all disciplines within the hospital when we first opened. And for example, our front desk staff prior to her coming here had been a surgical tech in labor and delivery. So her entire job focus was on beginning of life care. And it was a big transition for her. And she was really uncomfortable initially with discussing end of life care with patients. Bringing that up was really difficult for her. And this was reassessed after implementation of the project as well. Next slide, please. So data points that we found in the end for screening, we hit 100% of our target. Initially, what we found was that 25 to 27% of patients had documentation on file, which is where the 75% without came into play. And by the end of our PDSA 4, we had reached 41.2% of patients with advanced care planning documentation on file. It was a little short of our goal of 50, but we felt very pleased that we were able to affect such a significant change. And to be honest, the 50% was just sort of arbitrary in terms of we felt that it was potentially feasible within that time frame to double the percentage. And the Where I Stand scale, we had 100% usage once we began using it. And as I've mentioned before, the mean SURE test score, there was not much variability in there. Typically what we saw was patients who experienced any decisional conflict. It was more based on support system involvement and family involvement with their discussions, or if they were available to be present for the visit. A lot of them that took the packets home, they were here alone for their visit and they wanted to go home and have these discussions with their family members and bring them back. And really, I thought maybe it would be based more on how sick they were or a higher class of heart failure. That didn't really seem to play into that at all, though. Next slide, please. This is a run chart regarding our positive screening in terms of having the documentation on file. Initially, we had a big spike when the implementation began, of course, and then we see a drop, and that is where we were starting to lose or miss some targeted patients because the front desk staff simply couldn't keep up. Once the RN and the MA began the screening, it picked up a bit. In PDSA 3, we had some staff out and some patients decided to take the packets home and bring them back, but that improved as staff came back. Next slide, please. Use of the Where I Stand scale. There again was a big drop initially, but once we adjusted for who was doing the screening, that utilization jumped up to 100%. Next slide, please. And the mean sure test score, I feel like this run chart really shows well that there is very limited variability in those scores. Next slide, please. This is one of my favorite run charts, and it looks very boring and very simple, but the team engagement screening I felt like was really key in this whole project. I think maybe if there were more staff involvement and staff training for staff members that don't necessarily come to mind as someone that you would think would be initiating this conversation, becoming involved in that piece, it makes a big difference in both the level of comfort for the whole office and for the patients. So initially, I had developed this scoring guide and a form. They filled it out. The highest score that could be achieved was a 42, and that would have indicated complete level of comfort with having this discussion with patients. The first time it was initiated, it was a 17.1. The average score was 17.1. And when we did this again after implementation of our project, so 8 weeks in, it was at 34, which was a huge improvement. Next slide, please. So just as some discussion points, strengths of this quality improvement project, I felt like was empowerment of both patients and team members. And I feel like that was equally spread across the board. And I think increasing the level of comfort with the staff members was really key in setting the patients at ease and having these conversations. And in summary, the percentage of patients with ACP documentation on file did increase, although we didn't see it increase to quite what we had set as our target. And the patient, or the team engagement, increased from 17 to 32. I misspoke earlier. I said 34. It was 32. I apologize. Next slide, please. We felt like, based on the results of this, that shared decision-making improves patient care through a patient-centered lens. And I feel like the shared decision-making and the decisional conflict assessment were very helpful in terms of getting the patient just to have this conversation. It's really hard to sometimes gauge how a patient's going to receive this information. A lot of patients receive initiation of this, let's have a talk about your goals of care and how you want to be treated at the end of your disease process. They view that as, oh my gosh, I'm dying, you're trying to get me to plan my funeral. So using these tools was really helpful just in terms of getting that conversation started and getting the patient comfortable with understanding where they're at in their current disease state and what the actual goal of that conversation is. The findings were consistent with prior publications that I had listed in my literature review, I felt like, and both the staff and the patients felt more empowered by using these tools. Next slide, please. Some limitations to this were our clinic size is very small and we have very poor diversity amongst our patient population, which made generalizability a bit tough. We also have a very high specificity of diagnosis here. During this study especially, we were only treating heart failure. We have since expanded very slightly to include pulmonary hypertension, amyloidosis, and hypertrophic obstructive cardiomyopathy. But even then, our diagnosis structure it's very limited here. Efforts made to mitigate these included limited time off for the providers. And the reason for this is we only have 2 providers within this clinic. Myself, I'm here Monday through Friday, and the physician who's here only Monday through Wednesday. And patients from both of these providers were included in the projects. We tried to make adjustments accounting for space because we only have 3 exam rooms, which makes it difficult when 2 providers are here to have these prolonged conversations. These discussions, they make the visit at least 20 minutes longer on average. And we don't have a break room. We don't have a conference room. There's no additional space that has any level of privacy that we could take patients to try to have these conversations and keep these exam rooms open. Next slide, please. We did increase the number of patients to 41.2%. We celebrated that tremendously. We did increase the staff level of comfort with addressing advanced care planning documentation, and I can't stress enough how important that is. I feel like it really brought us all closer together as staff, and it brought us closer to our patients. We do have a plan for expansion of these interventions, both outpatient and other specialty clinics and inpatient with heart failure patients. We have not started on that yet, though. And this QI project was able to be used for facility magnet reapplication. Next slide, please. It's my references. Next slide, please. So just as some facilitated discussion, guided questions, how do you guys feel like we could better engage patients in this ACP discussion?
So they can chat, but they can't speak. Megan, if anybody raises their hand, I can unmute the microphone. But from our experience here, engaging them, I think is better in person. When you're seeing them, we've done a lot of information out to people that we don't get high responses to. And unfortunately, I think you're probably aware too, that one of the biggest challenges is we often get requests from the caregivers, but the client themselves has difficulty speaking about said things. So.
Absolutely. And I'm curious if anyone has any suggestions for how to better implement this system-wide. You know, there's a huge disparity between disease states and how these are managed in an outpatient setting. So if there's anyone here from another specialty clinic or from anywhere that has a good idea, I would be open and receptive to anything and appreciate it.
We can definitely get you some feedback on that as well.
Awesome. And then if you guys feel there are any tools that could have been added to make this more effective, I would be very interested in hearing that. There's always room for improvement. We're always looking to grow and provide better services to our patients.
Allie, what is one of the things that stuck out to you as a potential tool, being hands-on in it? What could have created better outcomes if you had access to it in the beginning?
I think if we had access to a notary, that would have been really helpful. So the hospital itself provides notaries here, and we were able to, on most occasions, get a notary down here. But I think if somebody within the clinic were certified to be a notary, it would have been very helpful. We had to try really hard to coordinate patient times for availability with notary time availability within the hospital, and that was a little challenging. We did have a couple of instances where we had to have the patient come back when a notary was available.
Great. Yes, notary. So another question for you. Advanced care planning, there is National Healthcare Decisions Day, obviously, if everybody in here isn't aware, which we do a lot here in Louisville through a planning group to help get information out there on advanced care planning. I can't recall, but the tool that you utilized, you mentioned a couple of them in the beginning of the PowerPoint. Can you tell us a little bit more about those particular things that you use to measure?
Yeah, so the Where I Stand scale, it was, I don't know if any of you are familiar with the KCCQ-12 scale, but it was very similar. It has a sort of a variable scoring guide, and you use this to determine from most comfortable to least comfortable how well this patient feels able to make a decision regarding specific things regarding to their diagnosis, to their end-of-life care, to their goals of care. And then there are a couple of questions at the end that are open-ended, just asking if there's anything else that wasn't mentioned throughout the conversation that they feel is important culturally or ethically to their end of life care. And then the mean sure test is just, it's very short and very dry. Do you feel like you could make a decision? Mitigating factors affecting that. Is it because of support that you feel like you don't? Is it because of lack of understanding of your disease state or your current situation? It's very cut and dry and straightforward.
You had said that you implemented shared decision making. Is that through your experience a preferred method? Would you encourage that we utilize the same method for this approach?
Absolutely. I feel like it really, shared decision making really empowered the staff more than anything. And I can't say enough how important that was, and really more how important we discovered it was during this project. I think everybody being comfortable with talking to the patients in general regarding the subject really helped the patients to be able to understand more that we're not giving them a death sentence. We're not telling them that they're dying today. We're just trying to make sure that they're cared for in the way that they want to be cared for moving forward.
Oh, that's a great way to say it there. Absolutely. And touching a little bit more about your implementation as you went through with the shared decision making and the teams working together. So I'm envisioning training. So you're training and educating every member of the staff on the forms and conversation. And then did you shadow each other? Like, did you have a buddy in the room the first couple times you did it, or?
We did not, but that would have been a really good idea, actually. No, we had a discussion beforehand, and I just explained initially to our front desk staff and then to our RN and our MA afterward what we were trying to target with the screening process. And as they encountered some pushback or some questions from the patients or family members about why we're doing this, we talked more about how maybe to present it to the patient or to the family so that they feel more comfortable. And one of the ways that we discovered made it a little bit less terrifying for the patient was to present it as, we're not telling you you're going to die today, but if you were in a car wreck and came in tomorrow, we want to make sure that if you're not able to answer for yourself, that you're taken care of in the way that you want to be taken care of. And almost immediately that set the patient at ease. They were much more amenable to talking about this and less resistant to the idea of, it's a lot less scary to talk about, I want to be treated the way I want to be treated, than it is to talk about, I think I'm going to die, which is how it's perceived.
I want to write down every word you're saying right now. I'm so glad it's recorded so I can go back and listen to it again, because the way that you are speaking about it is like, it's so difficult for us as practitioners to know where to begin with that conversation. I think once we get started and we kind of ease in, obviously we get a little bit more comfortable, but to start out that conversation is
it's hard.
Yeah, it is hard. And in our experience anyways, what you said is absolutely 100% correct. Once you get past and over that hurdle of having the conversation and people realize that they are making positive choices for their future that reduces the burden on themselves and their caregivers, and you're empowering them to make their decisions for themselves. But none of us want to face that we're going to get there, but we're all going to get there one day. So tremendous thank you for everything that you're doing to facilitate that conversation and sharing your knowledge. And I can't wait to hear more and collaborate with you. So
absolutely. Thank you. I really appreciate your time.
You're welcome. It doesn't appear that we have any more questions. I could go on all day probably, but
I know I could talk about this stuff all day too.
Right.
Once you get into it, it gets really not exciting. That's probably not the right word, but there's such a hole there, a big void there in the community. And it's just
exactly
an topic.
Yeah. And with more resources available out there and knowledge, you're right. It's hard to put words on it. It's invigorating to be empowered and to educate and to, facilitate people making decisions for themselves. So,
Absolutely.
anyway, we thank you so much, Miss Allie Megan Williams, and congratulations on finishing up your doctorate. You said earlier, I think.
Yes,
Um,
ma'am. Thank you.
that is we're all giving you standing ovation. You can't see it, but we are. So I just want to thank everyone again for joining us today for the patient-centered approach to increase advanced care planning documentation in an outpatient heart failure clinic. I'd like to remind you that we appreciate all of your feedback, and this session is eligible for your continuing education credits. Please complete the evaluation for the session contained in the email you received this morning with the subject line of OAC 2023 post-session evaluation link, April 15th through 19th. I know that we're all very busy, so please just take some time away to complete those evaluations. They really help us to plan and to let the speakers know what your feedback is. So again, thank you, everyone. Thank you, Allie Megan Williams, and have an absolutely great rest of your day. Please join us in just a little bit for our closing session. We'd love to see you there.
Thank you. You guys have a good afternoon.
Thanks. Bye, everyone.